You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 6, 2024. This week, Tirzepatide beats semaglutide in obesity, but GLP-1 agonist use is complicated. Heart failure outcomes, the misuse of meta-analyses in heart failure, and a potential major breakthrough in heart failure care. The first topic is the SURMOUNT 5 trial. Now, this was released by a Lilly press release. SURMOUNT 5 was a phase 3b trial comparing semaglutide and tirzepatide in patients with obesity and one comorbidity. Eli Lilly announced in a press release this week that tirzepatide produced a 47% greater relative weight loss compared to semaglutide. On average, tirzepatide led to a superior weight loss of 20.2% body weight compared to 13.7% with semaglutide. And at 72 weeks, tirzepatide beat semaglutide on both the primary endpoint and all 5 secondary endpoints of the trial. One particular secondary endpoint of the patients who achieved at least 25% body weight loss occurred in 31.6% in the tirzepatide group versus only 16% in the semaglutide group. The results, they said, will be published and presented at an upcoming meeting. This made big news on the business channels, but I am not sure it's a big surprise because in the trials that we've looked at, tirzepatide always seems to induce more weight loss than semaglutide. Here are 2 tensions to think about. One is that while tirzepatide induces more weight loss, semaglutide does have outcomes data, like the SELECT trial of patients with established heart disease. The question is whether this is a semaglutide-specific effect or a class effect, and I suspect it is a class effect, but it would be nice to have trial evidence and outcome evidence for tirzepatide. The second comment is that when I query AI on my Chrome browser, Perplexity, it tells me that there are at least 39 GLP-1 agonist drugs in development. So this is perhaps the tip of the iceberg when it comes to comparing agents in this drug class. All right, second topic is related. It's about access to GLP-1 agonist drugs. I've long said on this podcast that obesity is a medical illness, one that has severe complications. In the past, that distinction garnered some controversy, perhaps because obesity also has a behavioral and cultural component. Now, though, it is clear that GLP-1 agonist drugs are highly effective anti-obesity drugs, and in some conditions, such as diabetes and heart disease, are clearly disease-modifying, outcome-reducing drugs. But there are many-fold more patients with obesity who have yet to have a complication. For these patients, a drug that induces weight loss is likely going to be a preventive medicine. One problem is obviously philosophical, right? Because weight loss could theoretically be achieved through lifestyle interventions. But in patients who have tried but failed this approach, GLP-1 agonists stand a good chance of working. Yet there are going to be cost barriers. Last week, the major payer in the U.S., the CMS, put out a proposal in which they said that they recognize obesity as a disease and suggest reinterpreting the statute that excluded coverage of anti-obesity drugs for patients covered by Medicare, Medicaid, and Medicare Advantage. Well, I did not know there was such a statute, and I'm certainly not a policy person, but clearly the discovery of this drug class and its use is probably one of the most important medical questions, medical breakthroughs for the next decade. I've long worried that far too much of American healthcare is a simple wealth transfer from working people to the investor class and the medical industry. But I think GLP-1 agonist drugs are different, at least over the short term. They treat one of the Western world's greatest health destroyers, and that is obesity. That weight loss from these drugs reduce outcomes in patients with diabetes and heart disease offers a clue to their potential benefit in patients without these complications. Yet the question that everybody has to struggle with is how to pay for these drugs. Of course, I don't know how to pay for these drugs, but I'll tell you that there is a sign in our outpatient pharmacy that our plan does not cover these drugs. The explanation goes something like this. Basically, we can't cover these drugs or we would be bankrupt if we did. So obviously, it's going to be the same problem for any healthcare player. Now, I would also draw a distinction between given GLP-1 agonists for obesity in a Medicare-aged adult versus a child. How these drugs should be used in people who take them for more than 2 decades is a much different question than using them in a 65 or 70-year-old adult who's on the brink of a complication of obesity. I may be wrong, but I hope, and the emphasis on hope, that the incoming new health leadership will find a way to make these drugs more available to the people who are most likely to benefit. I would not even dare to opine on policy solutions. All I can do as a clinician is use healthcare as wisely and as congruent with the evidence as possible. And I guess I can encourage others to be as parsimonious as possible as well. Sadly, GLP-1A drugs won't make for walkable neighborhoods. They won't make for affordable, nutritious food or bike lanes, or they won't bring physical education back into American schools. For these are the big changes that might improve things for the next generation. But GLP-1 agonist drugs are clearly the next big advance in modern medicine. Finally, I have one final comment on GLP-1 agonist. I did write a formal critical appraisal of the SURMOUNT trial up on the heart.org Medscape Cardiology website. The title of my column is Has Tirzepatide Scaled the HFpEF Obesity Summit? To briefly review, because I did this in my previous podcast, SURMOUNT did deliver positive results for Tirzepatide in patients with HFpEF and a baseline BMI of 38. And more than 50 news outlets covered this SURMOUNT trial with glowing headlines. But in the column, I list at least 6 problems with this trial. And I think one is that the number of outcome events are extremely small. And the irony here is that this is what PI Milton Packer has used to shred AF ablation trials. I remember one time when Dr. Packer saying about if Castle AF was a heart failure trial, it would be laughed at because of the small number of outcome events. Well, if you go read my column, there are shockingly few heart failure events in the SURMOUNT trial. There were only 8 versus 5 cardiovascular deaths, more in the Tirzepatide arm. My summary would be, if we are to extend GLP-1 agonists to heart failure, we should have a properly powered trial, like DELIVER or EMPEROR or SELECT. SURMOUNT, I'm afraid, looks more like marketing than science to me. Okay, let's talk about a big blank spot in the evidence in heart failure. And this is the outcome of all-cause hospitalizations. I'm going to report on a paper in which I was a co-author. This was published in JAMA Network Open, November 27th. The first author is Dr. Ahmed Saeed, and the senior author, Andrew Foy. Our question was how to measure success of new therapies for heart failure. This is a modern question, right? Because in the days of old, heart failure trials measured one bias-free endpoint, alive or dead. They measured mortality. The foundational therapies of heart failure, like ACE inhibitors, ARBs, beta blockers, MRAs, they extended survival, period. These drugs were so good and the patients were so sick that mortality curves separated quickly and robustly. In addition, nearly all of these therapies also worked in post-MI patients who had LV dysfunction. Now, our success in heart failure has made it harder to show incremental gains. Newer therapies do not extend and cannot extend life any further, mainly because humans have an expiration date. And of course, if you stabilize heart failure, patients will live long enough to die of something else like cancer or pneumonia or trauma. But this is okay because many things in medicine improve life without extending life. Think AF ablation, PCI over medical therapy and chronic coronary disease, for instance. Heart failure experts have designed another endpoint in an attempt to measure incremental benefit of their new therapies, and their choice is cardiovascular death and HFpEF, hospitalization for heart failure. Of course, cardiovascular death is a fine endpoint. There's a small issue with adjudicating the type of death, but it is still a pretty hard endpoint with not that much bias. HFpEF, or hospitalization for heart failure, on the other hand, is quite a surrogate measure. For instance, the Emperor Preserved trial of epagliflozin versus placebo in patients with HFpEF illustrates the biggest problem with using hospitalization for heart failure as a surrogate measure. That is, EBA reduced heart failure hospitalizations over placebo, but the total or all-cause hospitalizations were nearly 10 times more common, and they were unchanged. In other words, in patients with HFpEF, hospitalizations for heart failure represents only a small fraction of total hospitalizations. In the EMPA arm, first hospitalizations were 259. Total all-cause hospitalizations were 2,500. Now, the other reason we should care about total hospitalizations is not just competing causes of the primary endpoint, but also because all-cause hospitalizations is a great way to capture benefits and harms. So let's say a new drug causes hospitalization because of low blood pressure, AKI, or aspiration pneumonia. This would be seen in all-cause hospitalizations. Okay, with that comment as background, let me tell you about the study that we did. Ahmed Saeed put together a long list of heart failure trials, which was published in 3 big journals, New England, JAMA, and Lancet. And this was to answer 3 questions. First, to determine the ratio of heart failure to all-cause hospitalizations. Second, whether reported treatment effects on heart failure hospitalization are associated with treatment effects on all-cause hospitalization. And thirdly, how often all-cause hospitalization is even reported alongside heart failure hospitalization. Dr. Saeed found 113 trials with 261 patients, and the first finding was that only about half of all heart failure trials, 53% to be exact, even reported all-cause hospitalization. And the rate of reporting had not improved over the many decades of this study. Our second finding was that the ratio of heart failure hospitalizations to all-cause hospitalizations was 46%. Now, that's pretty low, but better than the example I told you about in Emperor Preserved, where it was at about 10 to 20%. The ratio of heart failure hospitalizations to all-cause hospitalizations increased, i.e., heart failure hospitalization became a better surrogate of efficacy with trials that included more patients with class 3 to 4 heart failure. The ratio decreased, i.e., hospitalizations for heart failure became a worse surrogate with trials that included patients with better EF, think HFpEF. So our third finding involves some pretty cool Bayesian analysis. Here, we first described the association of the effect size on hospitalization for heart failure and all-cause hospitalization, and it turns out that it is strong, like an R-squared of 90%, which sounds good, but let me tell you more. The average odds ratio for all-cause hospitalization was way less than it was for hospitalization for heart failure. It was about half. So if the trial showed that heart failure hospitalizations were reduced by 25%, then all-cause hospitalizations would be expected to be reduced by 12.5%. And here's where the Bayesian statistics come in. We were interested in how much of a reduction in heart failure hospitalizations would you need to affect all-cause hospitalizations. And you can do this with a Bayesian analysis. And for a large trial with minimal uncertainty in estimating heart failure hospitalizations, to show any, that is more than 0 effect on all-cause hospitalization, hospitalizations for heart failure would have to be reduced by 16%. But to show a moderate reduction in all-cause hospitalization of 10%, then hospitalizations for heart failure would have to be reduced by 36%. And then to show a major reduction in hospitalizations, which would be a really important endpoint for a patient, a 20% reduction, heart failure hospitalizations would have to be a massive 56% reduced. So our comments. We think these findings on hospitalizations for heart failure and all-cause hospitalizations are probably the best case scenario, right? Because trials enrich themselves with patients who experience high rates of heart failure hospitalizations. In fact, we cited an observational study from the U.S. real-world experience. This was a Mayo Clinic study wherein only 12.6% of all hospitalizations 2 years after a heart failure diagnosis were related to heart failure. Now, while the correlation between heart failure hospitalizations and all-cause hospitalizations is high, we believe that this data argues strongly for the consistent reporting of all-cause hospitalization. Because if you don't report it, you can't assess how strong of a surrogate heart failure hospitalization is. Dr. Sanjay Kaul wrote the editorial and concluded that yes, it is okay to use cause-specific endpoints like heart failure hospitalizations to estimate a sample size of a trial. But all-cause endpoints should be pre-specified in the trial protocols and reported because if you don't report all-cause effects, clinicians can't know A, the degree to which the surrogate of heart failure hospitalization represents total health, and B, all-cause hospitalization captures treatment-related harm. For instance, one of the reasons that heart failure hospitalizations could have a large reduction and all-cause hospitalizations not have any reduction is that the treatment causes off-target negative effects. And we use an example of that. We use the DIGE trial as an example. In the DIGE versus placebo trial in patients with HFrEF, DIGE reduced heart failure hospitalizations by a sizable 28%. But all-cause hospitalization was reduced by only 8%. Largely because of a doubling in hospital admissions for DIGE toxicity. So in sum, when looking at heart failure trials which have no reduction in CV death and the only positive endpoint is heart failure hospitalizations, it is crucial to study all-cause hospitalizations. Based on this analysis of over 100 heart failure trials, it takes a robust heart failure hospitalization reduction to have any effect on all-cause hospitalization. And that is if the trial is large and has a low degree of uncertainty because of a large number of outcome events. A trial like SUMMIT has almost no chance of having a significant effect on all-cause hospitalizations. Perhaps that is why they did not report it. Tell your friends, we want to know how new treatment X, Y, or Z affects all-cause hospitalizations. Also, for the trialists, please give us this endpoint. All right, next topic is also about heart failure, and this is the misuse of meta-analyses by the heart failure community. Now, I'm going to pick on the heart failure community in the next segment, but I want to be sure that EP docs are no stranger to misusing a meta-analysis, and I'm going to tell you about a really dubious example. Exhibit A. Go take a look at a study from Desai et al., JAMA, 2004. I'll link to it. This was a meta-analysis of trials looking at ICDs for primary prevention in non-ischemic cardiomyopathy. Of course, the problem at that time was that no single trial had ever shown that a primary prevention ICD reduced death in non-ischemics. So these authors put the trials together, CAT, AMIOVERT, DEFINITE, SCUD-HEFT, but then they added COMPANION. And the problem was that COMPANION, which was one of the main drivers of the benefit of the ICD, was that it was a CRT trial, not a primary prevention ICD trial. This meta-analysis had a role in getting ICDs approved for non-ischemic cardiomyopathy. But it was wildly inappropriate to add COMPANION to this meta-analysis. Now, but the heart failure community has also a bad habit, in my opinion, of combining negative studies with positive studies to drive a claim that the drug is beneficial across all ejection fractions. And JAMA Cardiology has published the latest example of this, and it pertains to all-cause hospitalizations with the drug sacubitril valsartan. This was a post-hoc analysis of the Paradigm HF and Paragon HF trials. Right off the bat, I don't think this is appropriate because not only are the patients different, but the comparators were different. Remember, a Paradigm HF was sacubitril valsartan versus enalapril in patients with HFrEF. The mean ejection fraction was 29%. Paragon HF was sacubitril valsartan versus valsartan in patients with HFpEF, mean ejection fraction 57%. Extremely different patients. So here's what they did. They combined the trials and they looked at all-cause hospitalization. And what they found, if you looked at all of them together, sacubitril valsartan significantly reduced the risk of all-cause hospitalization compared with RAS inhibition, hazard ratio 0.92, upper limits of 0.97, p-value significant. But notice that they had to use the term RAS inhibition because the comparators were different. The 8% relative difference translated to about 2% in absolute terms in an NNT of 48. The authors did note that there was a heterogeneous treatment effect with the main reductions in all-cause hospitalizations of sacubitril valsartan in those less than 60% EF and no reduction in those with an EF greater than 60%. The authors then make these nifty colored figures with cause-specific hospitalizations across LV ejection fraction spectrum. These pictures and this mixture of trials let the authors conclude that, quote, sacubitril valsartan significantly reduced hospitalization for any reason, with benefits most apparent in patients with an LVEF below normal. This combination business is totally dubious in my opinion because it is a way of taking a non-significant HFpEF trial and mixing them with a positive HFrEF trial, which then outputs a small, statistically significant relative and absolute risk reduction. Then the drug, which is costly, can be marketed to nearly every heart failure patient. But I would argue that the paradigm HF patient with an age of 64 and ejection fraction of 29% is totally different from the 73-year-old, mostly female patient with an ejection fraction of 58%. They're just different. Paragon HF did not reach significance because A, HFpEF patients are different, and B, valsartan is a better comparator to the medium dose enalapril. The heart failure experts have also done this with the SGLT2 inhibitors, which were positive in HFrEF and non-significant in HFpEF, and boom, the meta-analysis is positive, quote, across the spectrum of EF. I don't like this. I don't think you should like it either. Meta-analyses can be good, but not when you compare and mix totally different patients and totally different trials. Okay, final topic. I want to talk about one of the most important things in heart failure care. And this is not going to be a talk about a study. I want to emphasize a review paper in the Journal of Cardiac Failure, first author, Dr. Sarah Chuzi. The paper reviews and explains and emphasizes the integration of palliative care into heart failure care. This is a very well-written paper. It's open access, and I want to applaud all of the authors, the journal editors, and the leadership of the Heart Failure Society of America for writing such an important paper. Now, I don't know what you all see, but in my neighborhood, heart failure care can be extremely heartless. I'm not sure the cause. Maybe it's quality measures. Maybe it's the oversimplification of guidelines, those colored boxes. But what happens instead of the relief of suffering is the misapplication of evidence that was acquired in ambulatory male outpatients to elderly, frail patients who have multiple diseases. Instead of integrating palliative care for an 80-year-old patient who has little help at home, walks with a walker because of pain, and has CKD and poor health literacy, this patient is on multiple meds, including sacubitril valsartan and dapagliflozin, which A, could never be paid for, B, cause hypotension and even more frailty. Instead of asking these types of patients what's important to them and focusing on care that relieves their suffering, these patients are treated as if they are wealthy ambulatory patients who can drive themselves to a heart failure clinic. Here's another case that drives me bananas. An older patient who is okay, they're limited, but they're hanging in there. They then develop AFib. Then they present with AFib and tachycardia, immediate left ventricular dysfunction. The echo shows a low EF, and boom, they're diagnosed with HFrEF. Instead of treating the atrial fibrillation, the patient is slammed with GDMT. But did you know that Dr. Deepak Kotecha from the UK published a 2014 meta-analysis of beta blocker trials in heart failure? And I'm going to link to it. All of the benefit they found of beta blockers occurred in patients in sinus rhythm. For those in AFib, there was no benefit. But no matter, The patient with AFib, soft blood pressure, gets long-acting beta blockers and sacubitril and dapagliflozin instead of digoxin and short-acting beta blockers for rate control. What I see as the benefit of early palliative care is that we increase the chance that some person, looks at the whole patient and stops this algorithm-induced torture. I bet the vast majority of cardiology clinicians don't even know there's a vast difference between palliative care and hospice, that palliative care should be started early, can be performed by the primary heart failure team or a specialty team, and be concomitant with heart failure care. I also bet that many listeners of this podcast don't even have access to a proper palliative care service. Based on what I've seen, I doubt many trainees get training in palliative care. Perhaps trainees are too busy learning about LV strain imaging. Okay, I'm going to stop this plea before someone says I'm ranting, but I see the next big gain in heart failure care as a major emphasis on palliative care. Realize this is a problem of incentive, right? Palliative care doesn't bring attention on social media. Nobody tweets about it. It's not easy to become a key opinion leader if you're an advocate for palliative care. Drugs and devices are the drivers of heart failure stardom. But in the care of many, if not most, patients with heart failure, nothing could be more beneficial than for someone to think about how best to relieve their suffering. If I were a healthcare czar, I would outlaw quality measures that incentivize clinicians to misapply evidence. Guideline-directed medical therapy can be transformative. It can render heart failure into a chronic condition rather than a death sentence. But guideline-directed medical therapy can also be a source of suffering for those who would never have been in a clinical trial because of frailty or comorbidity. Please do go to Journal Cardiac Failure, read this paper. I've linked to it. Do think about patient characteristics in the seminal trials, and please, someone sit down and have a serious illness discussion with a patient with heart failure. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a review, write us a comment. Write me a comment if you don't agree with something. You can go to theheart.org, Medscape Cardiology, and write a comment. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.